Renu, how are you?
Hello, Declan. I'm well. How are you today?
Good. Are you having a good week?
I'm having an exhausting week. It's been a big week.
Why?
We just had the ANZUP conference that Ben Tran and I convened. It was a fantastic conference, but gosh, it's exhausting.
And we're going to have a separate podcast, a little snippet.
Highlights. It was exciting, wasn't it? We had the GU cast debate.
That's what it was. It was great fun. So the ANZUP Annual Scientific Meeting is one of our best GU Oncology meetings in the whole Asia Pacific region. It's the annual scientific meeting of the ANZ Cooperative Oncology Trials Group, which is really good fun, and we'll talk more about that in an upcoming episode. Yeah,
it's a very unique conference, I think, because it really does have a truly multidisciplinary approach, and so I think that was well highlighted in the few days that we had.
Yeah, and it's again, I suppose we're still getting used to proper physical meetings coming back together, but it was really good fun to see lots of interdisciplinary colleagues and international friends.
Absolutely, and there was a really nice lighter side to it, because the ANZUP conferences are still small enough that you get to know the guests really well. You get to interact with them quite significantly, and so you get to know them on a personal level. And so I think we came away with some good international and local friends.
Great. Well, we've got a studio guest today on the podcast, folks. For those of you watching on YouTube, you'll already get a sneak preview. But why don't you introduce your good friend from UCSF days?
Yes, I'm thrilled to introduce a very good friend of mine, a mentor and friend from UCSF in San Francisco, Sima Porten. Sima, welcome.
Thanks for having me. It's been wonderful visiting.
Fantastic. So, Associate Professor of Urology at UCSF and also Fellowship Director. That's a fairly new role for you, isn't it?
Yeah, it's a new role and it's a really fulfilling one.
Fantastic. And this is your first time to Australia?
First time to Australia.
Well, Sima was one of our amazing international faculty at ANZUP this year, along with many others that you will see in our ANZUP highlights video. But Sima really has a lot of experience and knowledge in bladder cancer.
It's another bladder cancer episode, which is always popular. People always say, GU cast, too much prostate cancer. And everyone loves when we talk about anything except prostate cancer. So following Sia's great podcast last week, we're going to talk more bladder cancer.
More bladder cancer. And I think, Sima, you gave some fantastic talks at ANZUP. You talked about molecular subtyping of bladder cancer. You talked about treatment sequencing. And I think one of the most important things that I took away was that concept of bladder preservation, because that is a problem that we come across more and more. You were at our Peter Mac MDT this morning, patients who are BCG unresponsive, non-muscle invasive bladder cancer. Where do you go next? That's a tough problem, right, Declan?
Yeah, we all have these poor patients that you just run out of room. You don't know what we're going to do. We've done BCG, we've done this, we've done that. But there's a lot going on in organ preservation, both in the high-risk non-muscle invasive and in muscle invasive.
Yeah,
so
absolutely.
We're going to pick Sima's brains about these topics today.
Yeah, I think maybe you can start, Sima, by telling us a little bit about the treatment options for BCG unresponsive patients.
Yeah, I think this is an important space, and it's important for urologists to stay engaged. Because we are the primary captains of the ship in non-muscle invasive disease, right? We're the ones who meet the patient from the beginning and are with them through this whole journey and through endless cystoscopies and imaging and kind of working through that process. And up till now, radical cystectomy has been a real mainstay in the treatment of BCG unresponsive disease. Yeah. But I think as we've learned from our patients, as we've learned from other colleagues who care for our patients, and as we've learned honestly from our nursing teams, that patients really desire bladder preservation. And it's a huge goal for many folks in terms of managing their non-muscle invasive disease. And I think the question that I always get from patients is, do I have time to try something else? And that's a hard number to quantify, right? Because it kind of really depends upon what kind of BCG unresponsive disease you end up developing. But I think that there's been a huge explosion in terms of clinical trials in this space. And I think Dr. Danishman talked to you guys about one really exciting option, although it's a small numbers and it's early, but it sort of shows the enthusiasm and the sort of thinking outside the box in this. But so right now, what do we have in terms of options for our patients? One big one is actually systemic immunotherapy. That sort of creeped into earlier disease states from metastatic disease states. And I think it's still an important option when you look at the Keynote 57 trial, which was in the US, one of our first FDA-approved newer therapies for BCG unresponsive carcinoma in situ, you did see that some patients responded, 40% at 3 months, but that the duration was not long for this. So when you looked at a year, you had about 20% of patients kind of having a response. So if you responded, it was durable, but not a lot of people had that 12-month CR. And so I think it's still an important option to talk to patients about. It does require, if you don't give immunotherapy on your own as a urologist, it does require some coordination. But for me, I do talk about it, and I talk about, in particularly patients who have had a lot of urinary symptoms, that possibly this is something we can try. And if you end up to being one of these fantastic responders, excellent. And if you don't, the question will come up again, do I have time to try something else?
Yeah.
Right. And that's when we start bringing in a lot of the intravesical chemotherapies.
Yeah.
I think that theme, Sima, of is there something else I can try is really familiar to urologists and urology nurses out there listening, because these patients have often had bladder cancer for quite a few years. It's high grade, hasn't invaded the muscle, so thankfully specialists aren't automatically recommending a cystectomy or radiotherapy, but you seem to be teetering towards, well, if it doesn't respond and it's still high grade, maybe we'll have to talk about cystectomy. So it always does loom large in patients' minds out there listening to it. So that idea of, is there something else? Is there something else? But I should say on the immunotherapy side, in case there's any GU medical oncologists listening to the idea that urologists are going to start prescribing Pembro. You don't prescribe Pembro yourself, do you?
I do not.
But as regular audience members will know, we're all on for at least urologists being very well across systemic options in GU oncology. But I think
it does seem like a big jump, doesn't it? Because you're talking about something that's still very localized to the bladder. Mm-hmm. So our natural instinct would be to say, well, if you're BCG unresponsive, what's the next intravesical option? Exactly. Rather than going straight to systemic immunotherapy, which has its fair share of side effects.
And do you need to, I guess, up the ante at that point in time and take on those possible adverse events? And I think that's a difficult question to answer. I don't know. But you're sort of weighing it against this very totally different approach of radical cystectomy that comes with its own set of morbidity and recovery. We tend to use gemcitabine and docetaxel a lot in this space and have had really great response to it as well as tolerance, right. Meaning that patients are able to hold the medications in for the most part, and we don't see a lot of toxicity. We used to use gemcitabine and mitomycin a lot and had a lot more issues with mitomycin-based cystitis and toxicity, and that sort of decreased. And so although there's not any really randomized prospective studies looking at this, I do think the retrospective series and the response rates are decent in terms of giving it a shot. Yeah. And that cystectomy-free survival tends to be high, 70s to 80%. In terms of gemcitabine docetaxel.
So what does that look like? It's intravesical gemcitabine.
Yeah, and
weekly,
you give gemcitabine first, followed by docetaxel based on their specific alkaline properties. And one is given for about an hour to 90 minutes, depending on how long patients can hold it, drained, and then the docetaxel is given for about an hour, sometimes 45 minutes, depending upon how patients are doing with holding it. It's a longer treatment, so it's a longer time in a room. And it's given once a week for 6 weeks to start, and then monthly, like most maintenance chemotherapies. Most series report 2 years maintenance. Some have a year maintenance. I think that's probably less defined. Yeah. I think some maintenance is needed, but I think the optimal duration is still under debate. For that aspect. It's still a long haul. It's still a lot of treatments. And this is why with the approval of nadofaragene for Adenavac, which is a viral vector gene kind of based therapy using the adenovirus, that's been really exciting because it did receive FDA approval. We're hoping we were able to actually get our hands on it by the end of the year in the US, but the treatment dosing is very favorable. So the maintenance regimen for that, you still have your once a week for 6 weeks, but the maintenance regimen is once every 3 months. So when you look at the number of doctor visits, the number of time people are spending getting treatment, getting catheters, as well as the number of cystos they've got to have, it ends up being really great when you look at that risk-benefit scale. And so I'm very excited about that as well.
Yeah, and of course, like you mentioned before, the TAR 200, the bladder pretzel, that's also, especially given that this is an area of significant need, it seems like a very innovative, great idea to watch that space.
Yeah.
Just not yet approved or on the menu. So at UCSF, it's BCG with maintenance and a reinduction sometimes. We talked about that at Peter Mac MDT this morning.
Yeah.
And then next line beyond that is usually gemcitabine docetaxel.
Correct.
And that's approved in the US. It's accessible.
It's accessible. It's actually fairly cost effective. Those medications are old and they are cheap.
Yeah. Because we talked about it this morning, Renu. We brought it up. We had a case at the MDT, but our GU Medical Oncology team, Ben Tran and co, said it's not part of kind of routine care here. But that's sometimes because some of the older cheap drugs that are around just haven't, there's not a big pharma company pushing it forward to say, here's some trial data, here's this, here's that. But sometimes you just have to take them off the shelf rather than have the very expensive immuno-oncology agent that is all glossy and getting promoted. And so we shouldn't forget about some of these old-fashioned things.
Absolutely. And what's next after that, Sima? What happens if say they have a trial of intravesical gem and systemic docetaxel and you're concerned that they're not responding?
So if they've tried the intravesical gem docetaxel, that combination therapy, I still get sometimes asked, okay, I've done 2 lines of treatment. Can I do a third? Do I have time to do a third? And this is when I think that a lot of the data from Mike O'Donnell at Iowa is actually really illuminating and eye-opening in terms of looking at, okay, now you're on your 3rd line of a possible bladder preservation strategy. Is it such a bad thing if it was a small volume, high grade TA? I don't know. I think the metastatic potential of that is different than if someone got a large high grade T1, where then I'd be a lot more maybe pushy about considering radical cystectomy. I think also in this time I shared one clinical pearl is the more lines of intravesical therapy that you're delivering or bladder preservation, you've got to really be very regimented about monitoring the upper tracts, because that percentage of the upper tracts being affected with more and more lower tract preservation is much higher than what we usually quote patients, like 5 to 10%, right? It starts getting up there into 30%. And so you got to be really vigilant about that, as well as the prostatic urethra as being a source or developing recurrent disease. So I think you've got to be a good detective if you're going to continue with
I think that's a really important point because, the more lines of treatment that your bladder sees, the more you tend to forget about the important things like upper tract and prostatic urethra. So keeping them under significant surveillance is a really good clinical pearl.
And I think this is where the cysto study, which was designed as a pragmatic trial with Angie Smith and John Gore, and really, I think will answer some of these questions without having to do a massive 12-arm randomized control trial, right, about treatment sequencing. I think we'll get a lot of real-world data and a lot of data with an eye on patient-reported outcomes, because in general, that's what we're really talking to patients about. Yeah. We're weighing quantity of life and quality of life and how to help them make that best decision as they kind of move through the process.
So now, with some options for 2nd line and maybe even 3rd line treatments for BCG unresponsive non-muscle invasive bladder cancer, who are those patients that create the most red flags for you at the start? When they're BCG unresponsive, who are the patients that you say, you know what, I don't have time here? You need to move on to a cystectomy to prevent metastases.
Anybody who develops variant histology, even if it's non-muscle invasive, I really worry about understaging. Okay. The high-grade T1 tumors I worry about, particularly if you're starting to see lymphovascular invasion. That's not always reported by pathologists, but ours will report it. If you're starting to see high-grade T1, you re-resect, there's still T1, there's CIS. So it's a little bit of an analog looking at when you look at the EAU guidelines for very high-risk disease. Yeah. I think those are huge red flags, and I worry a lot about losing a curative window in those patients.
Yeah, those are the patients to keep, under extra scrutiny, I guess. Moving on a little bit to muscle-invasive bladder cancer. Now, at the ANZUP conference, Declan, we saw Professor Ananya Chowdhury she was from the Christie, a clinical oncologist. She gave a fantastic talk. She was thrown into the lion's den a little bit with a room full of urologists and whatnot, talking about bladder preservation in muscle-invasive disease. And, she sort of tried to dispel some of the myths and talk us through some of the realities of trimodality treatment, chemoradiation. What is your take on that, and what are the issues that we as urologists sort of need to be really aware of?
Yeah, I think it's definitely an underutilized option. There are many studies underway from our cooperative groups, like our SWA group. The number's 1806. Those numbers sometimes drive me nuts, but it is looking at chemoradiation with immunotherapy, and it's been a huge effort in terms of moving that through in terms of an option for patients, and it's because urologists are the first line of folks who see a lot of these patients. And we're also the last line because we're the ones doing the monitoring cystoscopies and trying to help patients through their side effects and managing non-muscle invasive recurrences, which I think is a little bit of a understudied area for these, but we kind of should be in this case. And I think that this is where these multidisciplinary teams possibly do the best, because it's hard. You send someone for chemoradiation, and if the radiation oncologist never sees them again, you're sort of like, this is so unhelpful, right?
Sounds similar, doesn't it, Declan? Sounds familiar.
And so the question is how do you build that team so you have engagement from everyone? And so because you never want to feel like, I think also as a physician helping a patient through this, that there's all these things that happen that were out of your control, and now you're trying to fix or put Band-Aids on or manage, right? Yeah. And there's probably a better way to sort of do that, but it would be great to still have your whole team to help the patient move through those treatment toxicities, the wins, the highs, the lows, all of that post-treatment. I think cystectomy sometimes is favored in that way because it's still, you've done the surgery and now you've got to help a patient through that recovery, right? I think for chemoradiation, you've made the diagnosis, you've done all this stuff, and it's like patient is gone for however many, like a month or two, and they come back and you're like, well, what happened? And they're like, oh, I have this happening and I have stool urgency and this is bleeding and, my skin here is not doing great. And you're like, what do I do with all of this? And so I think that's where this multidisciplinary team, and maybe that's a small part of why it's been difficult to create a system to help patients really have access to all these options. But I really do think it's an important
I thought one of the most pertinent things about that and concerns about that, and you brought this up, are the non-muscle invasive recurrences in these patients. And that can be really difficult to manage because it's difficult to re-challenge the bladder with intravesical treatment. And you made this great point that if you're not going to take out a bladder for muscle invasive disease, you certainly don't want to take it out for non-muscle invasive disease. So that can be a really difficult position to be in.
Yeah, I think it's hard. And sometimes patients are like, well, I thought it was, I'm going to have cystos and monitoring and scans, but I thought it was going to be done. Like I was, not going to have to worry about now this. And now you're telling me, okay, we're going to do BCG, the 3-year protocol because I have carcinoma in situ that's come up. And wait, I'm going to have another 30 treatments in the bladder, which is borderline working pretty good, but it's certainly going to take a hit when we start putting that treatment in, and that I'm going to need now cystos again for this long. And it's not a lot of patients. I've found a few things in the literature around 40%. I think at the Christie, their numbers are a little lower, 10 to 15%, but I think it really depends upon whether or not carcinoma in situ is present or absent.
Yeah.
And sort of what that patient journey looks like when you do have a win with bladder preservation. Because there is, it works.
Yeah.
there's a high cure rate from muscle-invasive disease, but then it's now what happens after. Just like we know for cystectomy and urinary diversion, long-term, how do you manage someone with a neobladder long-term, right?
Yeah.
Metabolic complications,
Absolutely.
making sure you have emptying. And for ileal conduit, peristomal hernia rates, how do you manage those? You
certainly need that infrastructure to allow patients to have access to all those services. But nevertheless, it was a great talk by Professor Chowdhury, and I think it was important for people to know that there is a very real option for patients going down that line.
Yeah, she was very impressive, wasn't she? But she did hit on a familiar theme, Renu, which is that surgeons don't value trimodal therapy, bladder preservation therapy for these muscle-invasive cancers as much as maybe we should. As ever, we're very aware that we are the custodians of this diagnosis. We find these patients, we look in their bladders, we take out these tumors, and if they are muscle-invasive, it's our responsibility to consider all the options and speak to the patients about what matters most. And actually, the nursing section and the psychology section at the ANZUP meeting is very, very strong as well. With really good talks from Rebecca Martin.
Oh, she was amazing,
About sexuality and body image and so on. But I think just what you said, Sima, about having these multidisciplinary environments to manage patients in is incredibly important for these huge decisions like, is it appropriate for me to consider a cystectomy, or will a trimodality bladder preservation approach help me achieve my goals in managing this difficult condition? But I think that nursing aspect was really strong.
It was fascinating, and Rebecca gave some fantastic talks. And Sima, you mentioned that you had a paper coming out about sexual function in women who've had cystectomy.
Hopefully, we'll see how the reviews go.
Yeah. Tell us about that. What did you find in your cohort?
It was a collaborative study with USC.
Okay.
With Dr. Banvadia, and also it was a mixed methods approach. It was more of a qualitative look at women in terms of their longer term survivorship who had undergone radical cystectomy and what sexual function looked like for them. And I think some big things from it were women actually are interested in regaining sexual function after, even very much older women, which was fantastic to hear.
Yeah.
So that was great. But that they lack a lot of the information and tools within which to do that.
Yeah.
It also was apparent that on the theme of organ preservation, that women who had organ preservation, preservation of the uterus, vagina, ovaries, that they actually experienced less detrimental effects in terms of sexual function than women who had to have all or most or a lot of those organs removed. Yeah. And so I think that was a big thing. And I think there's a lot of reticence or I think a little bit of shyness in talking about these things. But I think people are interested, men and women, about regaining their sexual function after these large cancer operations. And I think that maybe when you're making all these very complex decisions up front, a mention of saying sexual function's important. I know right now a lot of patients will tell me, I'm not interested in that. I want the cancer to be cured. And I said, well, when that happens, you will be. And so I want you to remember that it is that there are things to make this better, and that we've got to add that into our survivorship conversations and plans, because you really can't address everything at that one preoperative appointment where you're telling somebody about their muscle-invasive diagnosis, trying to figure out, do they need neoadjuvant chemotherapy, or should you do bladder preservation, planning surgery? You have all of those things to address. Yeah. But I think mentioning it then and building it into survivorship plans is really important.
Yeah, I think so. I mean, it is such an important aspect of recovery after a cystectomy. And like you said, address it before, but really do have some system in place to address it afterwards and make sure it's followed up.
And Sima, what sort of support do you have for bladder cancer patients in the US? Because these are all very important, but as was pointed out at the conference this week, often there is no resource, or in hospital systems there is no funding, for example, for an intimacy specialist or for psychologists with particular interest in sexuality and so on, or any good resources out there you can point us towards.
So we have the Bladder Cancer Advocacy Network in the U.S. and they're video-based, Beacon's video-based teaching and symposiums and seminars are amazing, and I think they actually empower patients to be able to ask and seek out these sort of resources. Now, once you know that you need a resource, how do you find it? That is definitely difficult and complex. Our nurse practitioner has really put in a lot of time, effort, and work, Christina Emodi, into creating lists of, okay, these are the sexual health experts, these are the pelvic medicine folks, these are the ones that take insurance, these are the ones that will do pro bono. Like, she's really taken it upon herself to create this aspect to it. But it's a little bit, you kind of have to piece it together. Yeah. And it's really been our nurses who have taken on this charge.
I think that's important to acknowledge that BCAN really is a very useful resource for physicians and patients alike. So
and here in Australia, Bladder Cancer Australia, and others will come to me. We'll put the resource up. But again, I'm not sure do we actually point patients towards them as much as we could. That's where oftentimes specialist nurses supporting patients and once that main consultation and decision making is made, then the other stuff can start to fill in. But it's really important. It was an important theme this week, and actually coming up in the next couple of months, we're speaking to one of our intimacy specialists, Victoria Cullen, who runs a fantastic resource called atouchysubject.com. Now, it's predominantly focused on prostate cancer, but I think there's a lot in there for everybody. Superb video-based resources and stuff, and Victoria is coming on the podcast in a couple of months when she comes back from Europe. So atouchysubject.com, another good resource to look at.
And I think it's important for, centres that do high volume bladder cancer to have, I think Declan, you call it bladder cancer champions, people who are really passionate about this and can set up the sort of structure that incorporates all of these pre-operative, post-operative decision-making challenges. And
there was a great debate.
Yes, the other debate. Sima was in a debate. Sima, have you recovered?
I think Declan and I ended up agreeing the whole time in our debate.
So that's right. That was with Dr. Declan Hain, one of our very own urologists from Western Australia. And you guys were either arguing for robotic or open cystectomy, rise of the machines, or openness is best, I think. Something like that. You're a high volume cystectomist. What is your practice like back at UCSF?
I thought it was very funny. I was being assigned the robotic aspect of it since I am a primarily open surgeon and cystectomist. I think that overall, all of the trials that have been done, and these have been pretty amazing to have surgical trials completed, both IROC with Dr. Cato in the UK, and then in the United States with Dippenpurik and Razor trial. And they show that robotic cystectomy can achieve oncologic and functional outcomes that are not inferior to open. And I think that is an important statement to make because, of course, as you bring in new technology, there's the old guard who will say, no, this is going to happen and that's going to happen, which is, it's good to be a little reserved, optimistic, but double check and make sure. So I think those trials were really big feats and important in sort of establishing this as a tool. But like anything, it's a tool. And it appears that volume actually is probably more important in intra-op and post-op care and actually surgical technique. And I think that's what, I think we both agreed on that point in terms of you shouldn't be doing one or two a year, and that's probably not the right thing for the patient. So that probably is the best sort of way to look at it as a tool. It is true you can get a little less blood loss. I actually like it post-radiation because I think you can I don't think you can feel very much with radiation planes, and I think you can see a lot. And then I do also have to say a funny little anecdote that I used was I had injured my knee pretty badly, and I moved my cases to robotic surgery for a few months as I recovered, and I was able to still continue my panel. And I think that's another thing that's brought up a lot is ergonomics and surgeon longevity.
Yeah.
So for listeners out there who don't know what that means, there's a really big difference between what Sima normally does, which is standing up in the operating room for really quite long
with
periods,
headlights
with headlights on, fully scrubbed,
on,
deep in the pelvis, doing this very complex surgery, versus when you're doing robotic surgery, you're actually sitting down at this comfortable console with your arms and legs very comfortably positioned. So even with a sore knee, you could operate all 4 limbs and do a cystectomy, which you probably couldn't have done that, or at least not for a while, or not in comfort with open surgery.
Yeah. So. It would have definitely been more challenging.
I mean, that's just a practical thing.
It's great. Real, I think it's a fantastic use of the robot.
And you know, it's very difficult to quantify this when people say, well, how do you justify expensive robot surgery versus open surgery for anything we do, especially prostate cancer, which is a really common cancer. But, you know, there's a whole generation of surgeons out there who were doing a lot of open pelvic surgery, and especially doing laparoscopic pelvic surgery back in the 2000s when we started doing that, with rotator cuff injuries and all sorts of neck injuries from these incredibly uncomfortable laparoscopic pelvic surgery positions in particular. And I think undoubtedly being able to sit down at the robot will extend your comfortable working lifetime.
Absolutely.
But very difficult to measure that, or certainly very difficult to have a health economic argument, because mostly people don't care about, you know, what happens to crook old surgeons.
And I mean, and one last thing, Sima, you know, Declan and I recently chatted with Sia in our Bladder Bonanza GU Cast podcast, and we talked about this is again numbers, the SWOG 1011 trial that compared extended versus standard lymph node dissection, and which showed that the extended didn't offer any further oncological control, but it did increase the morbidity of the operation and the mortality. And Sia did tell us that, you know, he needed to now, based on the results of that, he needed to now put a clip on the proximal aspect of his node dissection, so he forced himself not to go and do an extended, you know, a super extended node dissection. How has that changed your practice? Because we did a lot of those cases together when I did my fellowship at UCSF, and we had a lot of fun doing those node dissections. But has it changed the way you practice?
I do the same thing. I put a clip, and that's where I have to stop.
Really?
Just because you get into these routines and sort of, it's a little bit of dogma, or like this mantra, and the way that the same way every time is a big thing a lot of people say, right? And so you sort of get into these habits and routines, and for that one, there is level 1 evidence that we should not be going with our extended, super extended node dissections. And so I started putting a clip too.
Wow.
Yeah, that's amazing. If you haven't listened to that episode and you're interested, it was fascinating a couple of weeks ago. It's a big paper read out at ASCO, but it was one of those, this immediately changes practice study, even before it appears in print, because of the magnitude of actual harm to patients with an extended node dissection with no benefit. So,
and it's hard to change that practice because it's ingrained in you to do this sort of template. You know, Sia was talking about the Don Skinner times. That's how they all trained.
Yeah.
The clip is a good technique.
But we also talked about that memorial prostate cancer trial that we chatted to Kareem about last year, which was extended versus limited node dissection.
Prostate.
But unlike this SWOG bladder cancer study, in the extended versus standard dissection at Memorial, there was no difference in the node yield. So it was like 14 versus 12 nodes. And he said, look, it's part of the culture. If you're used to doing a lot of node dissections,
it's very hard.
It's very hard to stop. I'll just go up there and grab a few nodes out of there. So a clip is the answer.
Some way, or you tell your
fellow
person across
to the hand.
You have to be like, okay, I don't need to go past this, because, and it's an opportunity to discuss data too, and teach, and then you start creeping a little, and they're like, I think you had said that you're going to need to, you should stop at this area. And I was like, oh yeah, you're right. Okay.
Is that it? The operation's over. Yeah, okay, all right.
Good.
Sima, it's been so fantastic having you in Melbourne, and especially having you at the conference, but we're so glad you could stay on for a few extra days and spend some time with us.
Thanks again for having me.
It's been good fun, Declan.
And we have lots of great links to UCSF. We love having your colleagues on the podcast. And of course, Renu being an alumnus from there means we'll always have these great strong links. But do come back, maybe bring the kids the next time.
Yes.
Will do.
And you're our first in-person guest in this new studio.
Yes, that's
It's very cool.
Yes, we're still sort of tickle pink here in our new studio. Which means we can make a lot more content. Thanks to that. And Yeah, and also at ANZUP this week, we launched our first wave of our partnership program that we spoke about before on the podcast. So we're very grateful to the members of the pharmaceutical and device industry who have now partnered with GUcast to help us create all this content, and we're very grateful to them. They're all listed on our website, and you'll see some themed episodes coming through in the following months so that we can address topics of mutual interest, which should be good as well.
It'll be good.
Great. Well, that's all we have time for. Time to sign off, I suppose.
Time for lunch.
We're going to go for lunch.
Yes.
Take Sima for lunch. She's
Sounds
come all the
good.
way down here. But the least we can do is take her for lunch. So that's all we have for today. From me and Renu.
Until next time.
Yeah, we'll be back soon. We'll be back with that little ANZUP special soon. And we'll also be back with my Christchurch Magnus Opus that I'm
that's
editing,
a long-awaited
which is coming
one.
soon.
Yes,
it's a very special
for
episode
sure.
that will come in the next few months. So as ever, if you've liked what you've heard, please do rate and review us, subscribe, like, all that social media stuff seems to matter to help our audience find us here on GUcast. Thank you very much.